once again, I present Dr. John Suzuki.
Thank you, Dr. Massad. Good evening to all of you in the Middle East. Good morning to all of you in Asia, and good morning to whoever is in the United States, depending on your time zone. It's a privilege to be presenting for Dental News, and I will be presenting on SARS-CoV-2, the vaccines, the reality, the expectations, perhaps systemic manifestations, and perhaps where we can go for the future. But I owe it all to Dental News to put it together. I appreciate Dr. Ghanem participating, and of course, my colleague, my close friend, my professional ally, and a Loyola graduate of Chicago colleague, Dr. Joe Massad. Dr. Joe Massad is a speaker in and of his own right. He's internationally well known, and he and I have been on the podium together, and I can't really remember where this was, Joe, but we have spoken together on several occasions, including the American Dental Association National Meeting. But really, this entire Dental News program is coordinated by Dr. Tony Deeb. I have known Dr. Deeb for at least 2, maybe going on 3 decades. And I was also trying to remember when we first met and introduced to each other. And it was either at the Saudi Dental Congress or it was at the Alexandria, Egypt Dental Congress. One of those 2 is when I first met Dr. Tony Deeb. We have been close virtually every year at the Greater New York meeting and then other meetings throughout the Middle East too. But I have a few disclaimers I'd like to present before we get started with the official part of the program. I do hold faculty positions in 4 universities as shown on this slide: the University of Maryland, the University of Washington, Nova Southeastern University, and Temple University. And my disclaimer is everything I say for the next 40 minutes together in no way represents the policies nor the opinion of these 4 universities. I hold an appointment with the United States government, including the Food and Drug Administration. And once again, my position with the FDA in no way is represented today, neither their policies nor their opinions. I'm also the chairman and immediate past president of the International Academy of Contemporary Dentistry. And once again, my disclaimer is that in no way am I representing this group in today's program. But we are here to talk about SARS-CoV-2, commonly called COVID-19 disease, but the actual virus is called SARS-CoV-2, named after the severe acute respiratory syndrome virus from many, many years ago. Okay, how did it get its name? Well, COVID-19 was first reported just before midnight on December 31st, 2019, hence the name COVID-19. COVID comes, as you know, from the corona of the sun, which I'll explain in just a minute or 2. But for those of you that have followed the World Health Organization that have been investigating China, and especially Wuhan, over these last 14 days, you may have seen a report this morning from the World Health Organization that perhaps this particular COVID-19 virus was in fact seen in China at least 1 month or possibly even 2 months before New Year's Eve, December 31st. But corona, COVID, where did it get its name? It got its name from the sun, and from the eclipse of the sun that we saw several years ago, you can perhaps see that corona emanating from the sun, including sunrises that we see on the Persian Gulf, as shown here many, many years ago. But that's where the corona or the COVID gets its name, and the 19 gets its name from the date. So where did the virus come from? We thought originally it may have come from pangolins, or it may have come from bats. And according to the World Health Organization, that may be somewhat misleading because there has been other information that shows it may have come from other parts of China and not necessarily from these animals. But the current philosophy is that these viruses leap from animals to people and spark this present pandemic. But bats and pangolin, which are a form of anteater, have very, very similar mRNA to the viruses that have been identified from these two animal species. So that's where the similarity lies in terms of jumping from an animal to a human. With regard to the FDA, there are three primary objectives of the United States FDA when we deal with the therapeutics, the diagnostics, and the vaccines for especially the COVID-19 virus. First and foremost is safety of a particular product. Second is efficacy. Does it work? Third is manufacturing. Does the quality control make the 1,000 vaccine the same potency and efficacy as the #1 vaccine coming off of a clinical trial? With regard to the FDA clinical studies and biological laboratory studies, exhaustive work is done through the FDA prior to any introduction of a phase 1, phase 2, phase 3 clinical trial. This particular slide probably breaks it down the best in terms of sequencing of how a vaccine is approved, at least in the United States. And I'm certain that virtually all the Food and Drug Administrations or health administrations of other countries around the world have a very similar process. But after biological and preclinical trials, mostly on animals and other primates, the vaccine is tested thoroughly before it is proceeding to phase 1 of a clinical trial. Phase 1 of the clinical trial generally is a small cohort of patients, generally anywhere from 40 to 80 patients that are tested with the vaccine itself to look for any adverse reactions and to see if there are any other safety issues. If that particular vaccine is satisfactory after the small group in phase 1, then the FDA in the United States allows the particular company making the vaccine to proceed to phase 2. Phase 2 more examines the efficacy. Does this particular vaccine work in up to 80 to 100 different patients? And is there proof that antibodies are formed in the serum of these particular patients? And are there any other further side effects seen in phase 2? If phase 2 is a positive and everything seems to be satisfactory according to the data presented, then the company that next proceeds to phase 3. And probably phase 3 is what the world has all heard about, in particular for a vaccine. Phase 3 literally involves thousands, perhaps even hundreds of thousands of patients, usually across various generation lines, usually across various ethnic groups, usually involve multiple universities, and looking at far-reaching effects and other side effects of the vaccine. After phase 3 is completed satisfactorily, and at least in the United States, there are 2 that have been approved so far that I'll describe in just a few minutes. Both Pfizer and Moderna have so far been approved for use in the United States. The third one, Johnson & Johnson, is coming up in 2 weeks for a vote. But after phase 3 is submitted to the FDA, a green light is given to the company to begin distribution. This particular review of the vaccine proceeds for at least 1 to 2 to 3 and many, many more years, and it actually includes what's called a phase 4. The phase 4 is all the clinicians in the United States and including around the world that have access and have seen the particular patients. Any adverse reactions are reported during phase 4. There have been other instances where products have been recalled by the FDA in phase 4, and that's the purpose of phase 4, looking at long-term effects. There is, however, emergency use authorization of medical products and related authorization by the FDA. In this particular instance, which is in use right now for most of the diagnostics and the therapeutics, and also for the vaccines in the United States, emergency use is a go-ahead, a green light, but also it's going to be based upon looking at the long-term effects of these particular vaccines before full approval is given. Currently, there is a multitude of diagnostic tests currently FDA approved and currently being pursued, and currently there are at least 142 particular diagnostic tests that have been in use in the United States. The therapies include remdesivir, dexamethasone, among others. And of course, for prevention, we're looking at vaccines. But there are different arms of the United States federal government that look at vaccines, treatments, diagnostics, including antibody therapies, immunomodulators, and of course, antivirals. In particular, there are other respiratory diseases with similar patterns of symptoms and diagnosis. The World Health Organization published this viewpoint and this summary of the signs and symptoms of the COVID-19 virus, but in particular, the most common, according to percentage published by the World Health Organization, patients are febrile, they express fatigue, a dry cough, muscle aches and myalgia, and dyspnea, shortness of breath. The transmission rate and the particular times of the exposure to onset of symptoms is shown in this slide. In the United States, it ranges from 2 to 14 days. The FDA reports 1 to 12.5 days. And when a CBC is taken of a patient, generally speaking, the WBC count is not necessarily elevated, and lymphopenia is prominent throughout the course of the particular disease. So in particular, we see different patterns, and we also see different groups expressing different signs and symptoms. We've all heard about cytokine storms and why does the pulmonary tree and the lungs get affected first and foremost. Let's take a look at the scenario of a pulmonary tree after exposure, number one, of the patient to coronavirus. So this is exposure of the coronavirus into the pulmonary tree of a patient. After exposure of the coronary virus to a particular patient, the alveolar macrophages of the pulmonary tree and of the lung encapsulate and phagocytize the coronavirus. Macrophages act to cause a packaging of the coronavirus particles and, quote, package up the antigens and send the macrophage packaged coronavirus antigens off to other particular cells and groups, but also can serve as a reservoir for further coronavirus duplication. That particular duplication of the coronavirus does go to other lymphatic systems, other immune competent cells of the body, and large quantities of cytokines are released. During this particular release of cytokines, there are two major clinical features that we see as clinicians. In particular, damage to the lungs, and sometimes this damage can be seen radiographically in terms of fibrotic activity and inflammation, and other times we see leaking from the capillary walls, including increased fluid concentrations in the pulmonary tree. But the mechanism of viral attack on a particular cell includes the following. The spike proteins of the COVID-19 virus first attach to a susceptible cell. The virus RNA inside of that particular host cell yields viral proteins within the cell, and duplication occurs, and in particular, the phylogeny of the particular cell and particular virus duplicates, and large quantities are expressed and are also eliminated as shown here. We now recognize, and these are from early publications in China, that in fact the virus has a multi-systemic disease impact, and it's got huge effects on virtually all body organs due to the direct effect of the virus, but also its secondary, or now considered a primary effect, of the induced widespread inflammatory response. These are some of the very early papers published in the United States Journal of the American Medical Association from clinical investigators in Wuhan, China. We can see their reports from China published in our Journal of the American Medical Association, the comorbidities which we now recognize. Number one is increasing age, perhaps beginning at age 75 and older, and perhaps lowering it to 65 and older. Being male, and also pre-existing diseases are also comorbidities and higher risk factors. Hypertension, diabetes, especially uncontrolled diabetes mellitus and the presence of cardiovascular disease. In Science magazine, these have been summarized a few months ago, and I urge you to take a look at some of these earlier articles less than 3 to 4 months ago to look at the widespread impact of the COVID-19 SARS-CoV-2 virus on virtually all the systems of the body. As I mentioned, the pulmonary chest films also can begin to show the early signs and the more advanced signs of the COVID-19 infection. More interesting, however, the cardiologists have also looked at the diverse cardiovascular complications that the COVID-19 virus brings. Professor Nishiga from Stanford University probably is one of the forerunners at looking at the link of COVID-19 to cardiovascular complications. And he reports myocardial injury, heart failure, acute coronary syndrome, pulmonary embolism, and stroke, published a few months ago in Nature Reviews of Cardiology. And in fact, recently, the first patient actually died of a COVID virus infection, according to autopsy reports. So let's take a look at the components of the COVID-19 SARS-CoV-2 virus and see what the vaccine program is targeting. First of all, the spike proteins of the SARS-CoV-2 virus. These spike proteins are a target for the vaccine development and for antibody development against the spike proteins to render the particular virus inactive. In particular, if you take a look at this artist sketch of the SARS-CoV-2, you can see the spike protein is literally 360 degrees circumferring around the entire virus itself. The second component of the SARS-CoV-2 virus is the RNA, in which companies make an mRNA synthetic of the RNA of the virus. The RNA virus is also a target of the antibody response for vaccines. A third project looking at the particular vaccine development is using adenovirus, which is the common cold virus that has been inactivated to, quote, deliver particular proteins or deliver the RNAs from the inactivated SARS-CoV-2 directly into the immune response cells of the host. So these are the proposed mechanisms that vaccine companies are investigating. Currently, there are 63 labs around the world that are investigating the antibody response against proteins. Currently, there are at least 38 laboratories around the world that are using viral vectors, such as the adenovirus that I just described. The genetic code of the mRNA developed by 35 different laboratories around the world, including Moderna and Pfizer-BioNTech. There are 2 countries that are looking at the attenuated virus, along with 16 laboratories around the world, the primary investigators, China and Russia, that you're familiar with. The live virus, which was used in the mumps and MMR vaccines, are currently used by no investigators. So no one currently in the vaccine development for COVID-19 is using a live virus to instigate an immune response. So basically, these are the different components and the mechanisms by which companies are targeting. So once again, viral vector, Johnson & Johnson, AstraZeneca, and University of Oxford, and even China has begun to use the viral vector. mRNA, along with the 35 labs, Moderna and Pfizer-BioNTech. The attenuated virus, which is weakened by either radiation or heat or both, used by laboratories in China and Russia, and looking at the protein coat, the spike protein, 63 laboratories around the world. So in essence, what is the mechanism of antibody formation and how do IgG antibodies work best? In terms of the IgG antibody, we can see that if IgG antibodies are produced by the host against the virus, the IgG very quickly eclipses the effect of the COVID-19 virus as shown here. And with enough antibody response, of course, that particular COVID-19 SARS-CoV-2 virus is inactivated and killed with sufficient antibody response. Let's take a look at the viral vector, and in particular, some of these particular mechanisms for the COVID-19 virus. In particular, Pfizer, that the viral vector has well included, and the FDA of the United States gave them emergency use authorization approved a month and a half ago in December of 2020. The Moderna uses mRNA and uses lipid nanoparticles to encapsulate the mRNA for delivery into the host response cells during vaccine development. This company, FDA of the United States, also gave this company EUA approval in December of 2020. In particular, the mRNA is a duplication of the RNA from the core of a particular COVID virus, as illustrated here. The backing got the FDA advisory panel's approval and therefore went to the FDA, and the FDA granted EUA, as we all know by now. The effectiveness for the Pfizer COVID-19 is at least 90%, and some clinical trials showed 94% efficacy, up to 95% efficacy. The Moderna COVID-19 vaccine is also reported to be 94% effective, at least in the early results. Johnson & Johnson, which is up for vote week after next in the United States by the FDA, has some advantages and other disadvantages, but the advantages in particular are transportation of the virus does not require the very rigorous sub-zero temperatures of transportation of the vaccine, but also it's a one-shot. This particular company has investigated patients in the United States, Africa, Brazil, among other countries. There's well over 60,000 patients in their particular study. Depending on whose survey and reports you look at, there's been a 66% efficacy report, and the advantage also is that there is approaching 100% efficacy to prevent severe and life-threatening disease. Once again, Johnson & Johnson's viral vector COVID-19 vaccine has applied for FDA EUA approval, and the vote is week after next. How does this particular adenovirus work to deliver it? In particular, the vector binds to the membrane. The particular modified RNA is injected into the cells, and in particular, the viral vector instigates the immune response in the host response immune competent cells. So once again, Johnson & Johnson asked for EUA approval week after next. AstraZeneca and the University of Oxford, from our colleagues in the United Kingdom, also used the adenovirus, the cold virus, to deliver the genetic material from SARS-CoV-2 antigens into immune cells. There are over 30,000 patients in their particular study, and probably more at this point, and they reported 66.7% efficacy against COVID-19. And once again, they also use the core and the RNA to deliver it into immune competent cells. Day before yesterday, the World Health Organization recognized the Oxford AstraZeneca vaccine and recommended for all adults around the world to have this particular vaccine to be developed and to prevent further COVID-19 infection. Very recent. Our colleagues in Russia and in China use the attenuated or inactivated SARS-CoV-2 virus. For those of you familiar with vaccine development, you probably recall in the mid-1950s, the first development of the polio vaccine was in fact an attenuated, inactivated polio virus discovered first at my academic home, the University of Pittsburgh, in Salk Hall in the University of Pittsburgh campus, honoring Dr. Jonas Salk, the discoverer of the polio vaccine. The particular Sputnik 5 is reported to be 91.6% effective, as reported in Lancet a few weeks ago. And in particular, the data look pretty sound, at least according to the medical investigators. In China, which I don't know as much about because the United States FDA is not completely privy to either the Russia or the China vaccines, but in particular, China also is based upon primarily an attenuated and activated SARS-CoV-2. There are state-supported vaccine companies in China, and a third company, CanSino, reports a 65% efficacy of their particular vaccine. But the mechanism of vaccine development and the mechanism is still to boost the IgG response of patients receiving the vaccine. Immunosenescence, a relatively unknown question that is being pursued more and more as we seek research into the COVID-2. But as we now know, the immune response weakens with increasing age. Beginning at about age 65 or older, the host response is not as rigorous as it used to be when we were 26 years of age. The antibody response, including vaccines, also weakens with age. So as more data from phase 4 continues to accrue and be submitted to the FDA, vaccine companies will have to look and answer the questions. Should they use higher doses for older adults? Should they use a booster, which already is an investigation, especially for the variants from the UK and from South Africa, and probably from other countries that will come up with variants? But also, would additional adjuvants have to be used to boost the immune response, especially with a immunosenescence with the host response weakening with age? But COVID-2 reactive T cells are found in patients with severe COVID-19, and it's actually the T lymphocyte that is the key for immunological memory. The T and B cells work in concert with each other. The B cells do send signals to the T lymphocytes, and the T lymphocytes in turn provide the immunological memory, or how efficient is the vaccine over time. So this immunological memory is very, very important. As we know from previous vaccines, that immunological varies tremendously. The flu vaccine lasts for 1 year, at least in the United States. The tetanus vaccine lasts for 10 years. The MMR and others last over a lifetime. So immunologically is the biggest question, and that's why further research will be conducted to give us answers on the current COVID-19 vaccinations. Some of the research indicates that there is persistent T cell immunological memory in recovered COVID-19 patients. So in recovered COVID-19 patients, when different serum samples were taken, we now know that the T lymphocytes express immunological memory, and their particular immunological memory is measured over time and published in various peer-reviewed journals to give us a timetable of how long this immunological memory works. In other words, when do we need the next shot? In other words, when is our vaccination up? But in this particular recent series of studies, it appears that at least the immunity toward coronavirus doesn't last very long. So how long is not very long? So it could be 3 months, it could be 6 months, and it could be up to 12 months post-infection. So in particular, the coronavirus immunity is not going to be long-lasting and not certainly lifelong, like perhaps other particular vaccines. But the answer to the question is it's currently not known, but as a rule of thumb, the reinfection with the same seasonal coronavirus occurred frequently at 12 months after infection. So as a benchmark right now, I will give advice that probably 12 months we will need boosters of the particular vaccines, whatever vaccine we are using. The Moderna vaccine looks like early results show that the vaccine should provide the recipient to immunity to COVID-19 for at least 1 year of time. So this particular early data, not peer-reviewed yet by the Moderna vaccine, fits the particular data previously published on all coronaviruses. In particular, it appears that those particular patients are carriers or can be carriers in particular for the COVID vaccine. the IgG response, which is very, very early neutralizing antibody response to SARS-CoV-2, is one of the earliest immune responses after receiving the vaccine. As we know, IgG is also called the mucosal immunity. So the mucosal immunity is actually that particular antibody that serves as protection on our nasal passages and on our oral mucosa. And it appears that this particular IgA does in fact provide protection. So preliminary data look very promising, and those particular patients receiving the vaccination do in fact have a decreased viral load of COVID-2. This particular finding was published earlier today on February the 11th by our colleagues in Israel. And in particular, they report following their inoculation with mRNA vaccines that there was a 4-fold reduction of infections occurring within 12 to 28 days, even after the first dose of the vaccine. As I understand it, the clinical trials are continuing, looking for further viral load reduction after the second dose of the vaccine. So this looks very promising that in fact, those particular patients that received the vaccine are probably not going to be able to readily transmit the virus to those around them. What about in particular some of the other transmission rates that we now know? Research is continuing by the environmental professionals to look at how long does coronavirus live on surfaces. It appears that there is contact with an object containing the virus, and up to 3 to 5 days is now recognized to be survival for COVID-19 on metals, glass, and plastic. These are available in different settings on the CDC website and the Environmental Protection Agency of the United States. For example, in an elevator, we can also be able to identify COVID-19 from previous passengers that push an elevator button, or perhaps door handles in public settings, or perhaps even different types of credit card devices are all potential aspects of fomites that may transmit a microbiological agent, including the COVID-19. So therefore, how does coronavirus spread? According to the CDC of the United States, CDC spreads mostly through the air, through respiratory aerosols and droplets, and in addition to the particular inanimate objects that I just presented. But let's take a look at some of the research behind it, especially important for those of you in dentistry. According to the research published, for example, a sneeze produces a turbulent gas cloud, and the respiratory pathogen emission can go up to 26 feet in length after a particular sneeze that is not covered. Published recently in American Medical Association Journal just a few months ago. So in particular, let's take a look at the etiology of a sneeze. After a patient breathes with a non-mask, that particular virus particles can go up to 1.8 meters or 6 feet after we simply breathe and without a mask covering. After a cough, the particular virus particles can extend up to 6 meters in distance. And after a sneeze, as I've just mentioned, up to 9 meters after a sneeze. If you take a look at the etiology of the particular particles, obviously we know that the heavier droplets fall to the ground within seconds. So in a dental setting, it's those particular aerosols that we can actually see that are heavier fall to the ground very, very quickly. However, what we can't see in a clinical setting, the smaller droplets, less than 100 microns, fall to the ground in 30 minutes or longer. So therefore, that aerosol that is established is very, very potentially inhaled by clinical staff, inhaled by the dental staff, especially if the dental staff and medical staff remove their masks while the aerosol is still in place from a particular patient being treated. And this particular smaller aerosols, less than 3 microns, actually fall to the ground in hours. So there is a very, very continuous potential infectivity rate, at least when aerosols are produced. Same is true for restaurants. According to the CDC, published in Morbidity and Mortality Weekly Reports of the CDC, dining out in restaurants is linked to increased COVID-19 risk. And in particular, if we take a look at the 4 different venues with the risk factors for COVID transmission, it appears, according to the CDC, that these particular venues have the highest risk for COVID-19 transmission. So if we take a look at the sequence, bars and coffee shops are ranked number 1. Churches, religious gatherings, synagogues, mosques are number 2. Gym is rated number 3. Restaurants are rated number 4. If we take a look at some of the early research published from Guangzhou, China in 2020, in particular, let's take a look at a restaurant scenario that was reported. In this particular schematic of a restaurant that has been very well documented, this particular customer dining in a restaurant first reported COVID-19. Within a matter of a few days, looking at the infectivity rate and based upon the flow of the heating ducts or the air conditioner units, depending on if you're in a warm climate, those particular heating ducts or air conditioning units push the virus from this particular customer virtually all throughout the restaurant. So air conditioning may also be responsible for spreading COVID-19. So certainly in the Middle East, especially in the summer, air conditioning may be at least partially responsible for spreading COVID-19. I found this very interesting, and won't give the airline particular venues, but which venue is a higher risk for COVID-19 transmission? The New York subway system or an indoor restaurant? It's interesting to note that in particular, it appears that the air inside of a restaurant may be at least 2 to 3 times, quote, dirtier than that of the New York subway system, because the New York subway system reports that they have N95 filtrations throughout the entire subway cars, and within a matter of 2 to 3 minutes, the entire subway car is filtered, which is very similar to airlines. And N95 filters in airlines have a good filtration rates, and also within every 2 to 3 minutes in an airline, their particular air is pretty much cleared. But in particular, according to the New York Times investigating the New York public surveys, 97% of super spreader events can take place indoors. New York City subway cars are safer than most restaurants and classrooms when it comes to COVID. Poor oral hygiene also increases the risk for COVID-19. So according to the British Dental Journal and other journals, oral hygiene may play a role in COVID risk, but also COVID transmission. So I urge you to have all your patients have optimum oral hygiene, and my preference is to use power brushes in particular for that particular approach for those patients who can afford it. But other investigators have also reported that correlation of poor oral hygiene could affect the accuracy of SARS-CoV-2 tests. In particular, looking at SARS-CoV-2, and we can realize that the inflammatory response can also have an impact on those diagnostics and give either false positives or possibly false negatives. But can periodontal disease be a contributing factor for COVID-19 severity? The answer in preliminary findings appears to be definitely yes. If we take a look at periodontal disease and look at the MCC investigators from the United Kingdom, in particular the IL-6 interleukin protein, IL-6, is a, quote, culprit that makes COVID-19 so deadly. So IL-6 proteins that are produced in the inflammatory response of periodontal disease patients can in fact be a contributing factor. In terms of periodontal disease, our laboratory, when I was the dean at the University of Pittsburgh, looked at different types of pathogenic mechanisms of periodontal disease. And taking a look at this particular patient with active periodontitis, if you were to imagine a particular biopsy being able to be taken, looked at under the microscope, investigated for different immunological response, it appears that the periodontal connective tissue are literally filled with hundreds and thousands of inflammatory connective tissue and immune competent cells. These immune competent cells produce huge amounts of cytokines, a cytokine release, including but not limited to IL-1 beta, tumor necrosis factor alpha, IL-6, and perhaps many other inflammatory mediators, including matrix metalloproteinases. So this cytokine release in particular can also contribute to other cytokine storms that have developed by the COVID. So the cytokine production can be of COVID-19. So the lymphocytes, take a look at the particular role of cytokines, and our laboratory has published a series of papers looking at this antibody response that we know that lymphocytes produce huge amounts of cytokines. So COVID-19 infection can lead to a form of severe cytokine release syndrome, commonly called the cytokine storm. IL-6, a pro-inflammatory protein, appears to lead the way, and IL-6 levels potentially can track COVID-19 severity, as reported first by the Seattle Institute for Systems Biology a few months ago. Let's take a look at a potential pathogenic pathway that I put together based upon the data. Once again, this is speculation, and we are going to take a look at what potentially could happen immunologically in this particular disease. So COVID-19, after exposure to a patient, if there are risk factors present, such as obesity, high blood pressure, hypertension, diabetes mellitus, periodontal disease, smoking, the COVID-19 can lead to a SARS-CoV-2 infection and an immune response starting in the pulmonary tree and resulting with a COVID-19 infection. Alternatively, a challenging SARS-CoV-2 into a patient's pulmonary tree can lead almost immediately to a cytokine storm, leading to increased volumes of interleukin-1 beta, tumor necrosis factor alpha, and interleukin-6. And of course, there could be correlations between the two. But these are two potential mechanisms. And yes, there is a crisscross back and forth where the immune response classically can lead to a cytokine storm, perhaps as late as 2 to up to 14 days later, according to the transmission rates and the infectivity as we now know it. Antiviral mouthwashes can be used to help curb coronavirus transmission. The answer to this question, published in the prestigious Journal of Dental Research, is definitely yes. The antiviral mouthwashes are identified to be, in particular, 2 primary ones that help curb the virus concentrations in our patient's oral cavity or within our own oral cavities too. In particular, the studies and investigation too is really successful in minimizing the risk of COVID transmission. So rinses containing cetipyridine chloride or povidone can dramatically reduce the oral coronavirus load. So I hope all of you as dental practitioners have your patients pre-rinse with these particular products, in particular, cetipyridine chloride or povidone according to the manufacturer's directions. So periodontal patients should be counseled, as my clinical recommendation, that inflammation may increase their risk for COVID-19 infection. There is a newly recognized disease that's a springboard from COVID-19 infections. It is something called long COVID-19. Sometimes the common term is called long haul COVID-19. We don't know much about it, but there is a certain subset of patients that have a COVID infection that lasts for at least 6 months or longer. The classic symptoms include fatigue, tiredness, and brain fog. So long COVID-19, what is it? This was a study of over 3,762 patients and counting. The spectrum included 56 countries, and the conclusion from this particular early publication, published about 6 weeks ago, showed that COVID infection could in fact last for 6 months or longer, and symptoms include fatigue, tiredness, and what is called brain fog. So in closing, my time is up, and I'd like to once again thank the organizers, and especially Dental News, and especially my colleagues, Dr. Massad, Dr. Ghanem, and especially Tony Dib, the editor-in-chief of Dental News. So once again, I'd like to turn the program back over to the organizers and have Dr. Massad lead the discussion.
Thank you so very much, Dr. Suzuki. Very, very informative presentation. We have so many questions that I'm sure we're not going to be able to answer all of these. But in the meantime, I would like to go ahead and get some comments from our panelists, Dr. Ghanem, and if you would give us some comments, and then we'll go straight to the Q&A, the questions and answers.
Sure. Thank you so much, Dr. Massad. Thank you so much, Dr. Suzuki, for this wonderful overview. I think with so much information around all over the place, it's important to keep things scientific and to have a lead for our discussion. I think that was a wonderful overview, and I thank you. So just for, I would like to organize my comments in the next few minutes and try to put them in two or three different areas. And the first one, as you well showed with your presentation, is of course the safety. So the first thing we would like to discuss regarding the vaccines, which is a hot topic nowadays, is basically how safe are those vaccines? And as you pointed out, we have different types of vaccines, some of them using older techniques, like the inactivated viruses, like the adenovirus, which has been used for many decades, as you pointed out, versus the newer forms of vaccines, which use techniques that have been used for the first time with the anti-COVID vaccinations, like the Pfizer vaccine, as well as the Moderna vaccine. So, I'm sure you're hearing comments from everyone, the pro-vaccinations as well as the anti-vaccination groups, regarding the safety of these vaccinations, and for some, using older techniques like the attenuated adenovirus seem to be the way to go, because these techniques have been used for many decades now and they appear to be safe. And for others, using mRNA rather than DNA vaccines might show decreased issues as far as the safety is concerned. So it is important to point out, I would like to hear your comment about this, like your short advice for us. For example, right now in Lebanon, we're getting only the Pfizer vaccine. So what would be your point of wisdom regarding the use of a new technique like the mRNA vaccine? And what do you think the intermediate and long-term safety effect of this new technique of vaccination would be?
Thank you, Dr. Ghanem, for your participation as a panelist. And the question is a very, very interesting one. And once again, just as a disclaimer, as a special government employee of the U.S. Food and Drug Administration, I can't really give any favoritism toward any company or vaccine developer. But what I can say is that I would trust the Food and Drug Administrations of your respective countries, the FDAs of each one of your countries, or the Department of Health, including that of the United States FDA, has gone through exhaustive data, thousands and thousands of patient files and data, looking at the safety, efficacy, and manufacturing processes of the vaccine. So I would encourage you, despite whatever vaccine is available in your countries, I would get it immediately. And I would recommend to my friends and family to also get the vaccine as quickly as possible in the different lineage. So with regard to your second comment regarding which one might be different types of delivery systems and clinical outcomes, whether it be the attenuated older version based upon the polio scheme decades old, or one of the newer advanced high-tech schemes using mRNA copies of the core of the SARS-CoV-2 and then using that as a springboard. Well, primarily the developers for the mRNA vaccines have been using this particular technique in terms of research trials for almost a decade of time. So it's not necessarily new among immunologists. However, as you pointed out, it is very, very new to the world and a very, very novel approach to vaccine development. So both of these approaches are safe. Both of these produce different efficacy rates. And once again, I encourage you as clinicians, I encourage you to tell your patients to get the vaccine approved appropriately in your respective countries.
Super. Thank you so much. And this is basically what we've been trying to promote and raising awareness about the safety and the efficacy of the vaccine, and going through the phase 3 data that have been published regarding the different forms of vaccines that are available all over the world. It's great to see the efficacy ranging from, as you pointed out in your slide, from 60% to more than 95% and different types of vaccines. And the nice data that is coming out as well is the fact that it's not only decreasing the risk of getting the COVID infection, but it's also some early data, as you showed out, it's also preventing maybe the transmission of the COVID from people who have been vaccinated and getting the virus, transmitting it to other people who are not vaccinated. So that is an important idea that is coming out from the new studies. But it's important also to say that this should not tell us that vaccination should be only done by other people. So vaccination should be done for everybody. Vaccination should be done for the most, for 70, maybe to 80% of the population to be able to get to that herd immunity, so we can hopefully get rid of the transmission, and maybe one day get rid of the COVID infection and the SARS-CoV-2. Hopefully that will be a dream that we're all aiming for at this stage, by promoting the vaccination, which seems to be the only way to get rid of that virus. Now, I have one more comment, and I think we'll leave the floor to other questions from the attendees. And that comment being the fact that, and we get a lot of these questions, what about people who are vaccinated, and should they still continue to take all the measures for protection, using masks, not going into big gatherings, use of social distancing, etc. One of the ideas that we have to promote as well, and I'll take advantage of our meeting today to increase the awareness that even for those people who are vaccinated, we still can't transmit the virus. So until we get to that herd immunity, we still cannot say, let's get rid of that mask and let's get together again. Even for people who are vaccinated, we still can't transmit the virus to other people who are not vaccinated. So until we reach that herd immunity, maybe 70, 80% of the population that is vaccinated or having contracted the virus recently, I don't think we should promote that it is safe to remove that mask. And what do you think, Dr. Suzuki, regarding that very specific point?
Yes, Dr. Ghanem, I fully agree with you that despite the fact that some of us have had the vaccine and others too have had the vaccine, including the first shot or the second shot if it's so required, I fully agree that further precautions still need to continue until further notice. And at least the CDC in the United States recommends still using masks and still using other protective precautions despite vaccination programs. So absolutely, yes, we still need to be vigilant and until further notice by our health authorities.
Thank you very much. Dr. Massad and Dr. Deep, I think you have some questions from the audience if you want to raise those.
Yes, Dr. Suzuki, there's a question. If adverse reactions occur from the vaccines, what analgesics are recommended and when?
In particular, this also is somewhat controversial, and what I can say is that currently many physicians recommend ibuprofen 400 milligrams to be taken 30 minutes after the injection, first injection or second injection, but not before. So that's for 400 milligrams ibuprofen according to the manufacturer's directions, which is TID. In particular, there is an argument by some of the members of the Centers for Disease Control in the United States that if ibuprofen is taken before the shot as a preventive for the side effects or adverse reactions, that it may inhibit the arachidonic acid pathway and reduce the production of prostaglandin E2 and prostaglandin E3. To me, there's no data that showed this, and until further notice, I will still continue to try to obtain the discomfort and adverse reactions using, in particular, the ibuprofen preventively.
Thank you. Another question, and you may have already answered part of this. However, what relationship, if any, is there between previous vaccinations, such as the flu, vaccine, and current COVID vaccines?
There is evidence that is beginning to emerge that indicates that those with a history of vaccinations on an annual basis, especially such as the flu vaccine every year annually, may be in a better position to have a more robust antibody response. So it's very similar to the musculoskeletal system. If we use the musculoskeletal system during profound exercising in particular, that particular approach can enhance our musculoskeletal systems of our own body. The same is true with the immune system, that those who have had vaccinations in the past appear to have a very, very significant antibody response. So this includes not just the flu vaccine, but all the childhood vaccines that we have had before. The second comment I'd like to make along this line that also is not substantiated in peer-reviewed documents is that those particular patients that have been susceptible to the common cold, other types of respiratory viruses, it appears that those particular patients that have had respiratory viruses in the past, of course, the common cold, the adenovirus, appear also to have a very, very profound, robust immune response.
Thank you. This question is, well, what recommendations do you have to ensure that vaccines will take effect?
Well, there are several lay publications and immunologists have supported it that have looked at some data early on, not necessarily just the SARS-CoV-2, but it appears that, number one, getting a good night's sleep both before and after the COVID vaccine is presented to the patient appears to enhance a more robust antibody response. Other aspects include just the normal health venues that we've already experienced. In other words, to stay out of a high vaccination, low vaccination rate areas, and also trying to avoid exposure to further SARS-CoV-2, despite the fact that you've got the vaccination.
And then one final question is, are variants covered by current vaccines? You mentioned that, but I think maybe it'd be a good idea to go ahead and maybe repeat that.
It appears that preliminary data, especially from the Pfizer and Moderna vaccines using the premise of mRNA, appears to be satisfactory in terms of coverage against the variants, especially the UK and the South Africa. It has been questioned recently in the last 5 to 7 days about the efficacy of other vaccines against especially the South African variant. But data is not completely available yet, so I will comment that many of the vaccines appear to also be coverage against these variants.
Okay, thank you so very much. I think from all of us who have listened to this website, we've been enlightened, and I want to thank both of you for your attendance. And Dr. Suzuki, may God bless you and keep you health so you can continue to keep us healthy.
Thank you very much. And thank you for the organizers.
Thank you very much. And I think just before we end, there was one question that I will address very quickly if you allow. There's a question about how vaccinated people will still be able to transmit the virus. So it is important to note that, and Dr. Suzuki pointed out to that fact as well, that the vaccination does not happen over, the immune system is not built up after the vaccination overnight. So technically it's a dynamic process. And this is why we need the shot and then the booster. And then technically our immune system is not ready to fight that infection before we get to that high levels of IgG. So that period of time, we may still get the infection as well as transmit the virus. Now, when patients, when subjects are vaccinated and they build their immune system, technically they might still transmit the virus without really getting the infection, without having the COVID. And that's particularly true for people who have been touching other people as well as contacting them, and the saliva might also transmit the virus. So technically, they're functioning as a vector to the virus without really getting infected. So it is important to keep that in mind and to still take all the precautions, even when you're vaccinated, especially within those few weeks after the first and second shot, until the immune system is has built up a good immunity.
Thank you, Dr. Ghanem. Thank you all for attending. So please, if you have questions, I'm sure you'll be able to send those questions to Tony Deeb with Dental News, and hopefully we'll be able to answer additional questions. So I
Thank you very much, all
yes,
of you
thank
guys.
you all.
Thank you very much.